Hello, everyone. So I'm Youssef Saklawi. I'm one of the members of the CP Solvers team. Uh, Today, we're trying a new format, slightly different management reasoning morning report. We're gonna shift gears towards the why on how do we decide certain things about management. And I'm so glad to see so many familiar faces. Wasim was my fellow on one of my ID rotations. Zach is one of my co-residents. Oh, that's Miko, also one of my co-residents. Andrew, so good to see you, Yasmin. Hey, Julian, how are you all? Uh, I think this will be nice practice in general for like medicine, and like it's just like a small thought exercise, and I really, really look forward to it. We didn't choose a discussant for today. I was hoping for a discussion amongst all of us. Uh, if you want to participate, I would love it if you have your cameras open. We can like all discuss and then take it like step by step. So, but I think we can take it we can start. Let me. So the case today is a case that I had seen earlier last year. It's a 26-year-old female with past medical history, unfortunately, of a stroke, a ischemic stroke. And as part of the workup of the stroke, they found a carotid web in the left internal carotid. To those who don't know, a carotid web is like an outpouching of the vessel there, and there can be stasis of blood around there, and that can cause a stroke. Carotid webs are associated with fibromuscular dysplasia, with abnormalities in the heart and the blood vessels of the heart. And she had a workup done for that. Essentially, that was not found to have any other lesions in any of the vessels in the abdomen, or this was the only lesion that was found to have any abnormality. So she was admitted for stenting of that vessel. So stenting of the vessel was done to close that outpatching, prevent further strokes. And then you were the resident on the team, and you get a dreaded phone call from the microbiology lab is that one and two blood cultures collected in the ED are positive for GPCs, or gram-positive cocci. And this is a situation that a lot of people are put in, and I wanted to see what y'all's approach is to just GPCs, one and two GPCs in blood.
Did you say, Youssef, already if it was clustered or in chains? I forget already.
I haven't said, and why do you ask that?
That could be one clue to what type of organism this is, among other things.
Yeah, we haven't gotten any of that information yet. And Dhruv you raised your hand.
I was about to say the same thing. Specifically that because it's 1 out of 2 blood cultures, I'm looking to see what that blood culture speciates into. Because if it's staph epidermidis, we may think, oh, did the collection of the culture in the ED have some contamination in it? But if it's staph aureus, then the answer is no, you need to treat it because that is pathogenic. And is not likely to have been a contaminant. So I think the other thing too is that I would also repeat blood cultures and proper technique, make sure that you're sterilizing and all of that, and make sure that the cultures that you collect the second time before giving any sort of antibiotics also, check to make sure that the results that you're seeing are actually like real results rather than a contaminant.
Excellent. And this is where I had a question here, Dhruv. Like, I completely agree with your discussion, is that yours and Andrew's, is that GPCs, are they in clusters or are they in chains? Because that will essentially break up the discussion. Is it under staph species or is it strep species? And I agree with the discussion. Now, I was wondering, would you repeat cultures alone? Would you repeat cultures and start antibiotics, or would you monitor for symptoms in this situation?
I think the first question that I would ask, and Clara asked it in the chat, was why was the ED obtaining cultures in the first place, question mark? Was it because they saw that the patient had fever? Was it that there was something, was it that they had gotten an elevated white count and they didn't have a clear source? Was it that the patient was hypotensive? They had to start pressors, give fluids, and they thought, oh no, we're concerned that this is sepsis. For me, less is more. Keeping in mind the fact that you don't want to delay testing if it's if you have a patient who has the risk of quickly decompensating on you. As far as I can tell, this is a young-ish, I would say, well, this is a young adult woman with really only one issue, basically the classic cases that we typically see in more on the pediatric side than on the medicine side. And honestly, I would monitor for fevers, continue checking CBCs to look for, look for trending upward white counts, making sure that you were looking at heart rates and blood pressures, particularly heart rates in the case of this 26-year-old, because tachycardia in younger patients often appears well before hypotension. And so once, and if you have, I would say, fever of 101 Fahrenheit once, or 100.5 Fahrenheit times 2, so 38 Celsius versus 38.5 Celsius, then absolutely grab cultures, start antibiotics empirically, kind of taking sort of the neutropenic fever approach. But I would maybe just grab cultures and wait, not start antibiotics almost immediately. Great.
I love that discussion, Drew, of taking us through every single step of your thought process. And the initial blood culture was collected because the patient was initially transiently tachycardic, and so they went ahead and got cultures anyway, but there was no other signs of fever. This is the next best step in the question of 1 and 2 GPCs. Is, do we repeat cultures? Do we repeat cultures, start antibiotics, or do we monitor for symptoms? And there is no one single answer that definitely tells you. It will depend on the clinical circumstance. Like Drew was saying, essentially, if you have suspicion for infection, you would want to be more cautious and probably repeat cultures, start antibiotics. While if you don't have any suspicion, then you might monitor for symptoms or just repeat cultures. And that also depends on the level of supervision. So if you're alone at night, would you rather start antibiotics and then check with your supervising physician, or is the supervising attending there right at that time? And for them, they can make the decision as well. So like we said earlier, so GPCs can break into under cocci, there's staph and strep. Under staph, there are the staph aureus and the coag-negative staph. The coag-negative staph is part of the normal skin flora and are contaminants a lot of the time, except for one organism which I want you to remember, which is Staph lugdunensis, which acts exactly like Staph aureus. It's a long word. I'll put it in the chat shortly, but Staph lugdunensis is the only one that is basically, they call it the wolf in sheep's clothing. It's a coag-negative staph that acts like Staph aureus. And then there are the strep species, which are mostly pathogenic. So in this circumstance, we actually, to help us decide if it is a contaminant or not, we think of the organism. So the organism speciated as Staph epidermidis remained as 1 and 2. And the way we think about it are through a number of factors. So we think of the organism. The Staph epidermidis cause infections, so it depends. Do they have risk factors? So we also think of the host. Are they immunocompromised? Do they have hardware to make us think of biofilms? Does the patient have a syndrome that matches this organism? And how many blood cultures were positive? Were they taken from separate lines, from one line? Or were they taken from a line that was already there, for example? And these are like the number of factors that you would have to decide. So in this case, we did not treat, it was Staph epidermidis, and the patient actually underwent stenting. So the procedurist team went through endovascularly, through femoral access, went up and actually placed a stent in the carotid artery. It went on, the procedure happened without any complication, and we're fast forwarding to 2 days, 3 days post-op, when the patient developed a fever up to 38.5. And my question now is, what is your workup of this patient? So to reframe it, it's a 26-year-old with a history of a stroke with a carotid web status post-stenting, now febrile to 38.5 on post-op day 5.
Youssef, I would kind of reassess the situation again. So could be something new. It could be related to the initial, workup that was done. So obviously, like reassess the patient, start thinking about causes of infection in the hospital. The patient has been here for a minute. Make sure you check the lines. No signs of DVT, no signs of line infections, septic thrombophlebitis. Wounds would be kind of early for them to develop, but also see if the patient had like underlying wounds initially when she presents, even though she's a young person who did not have really issues with mobility before that. And then, repeat the cultures at this point. Make sure, again, something to add to the workup that was done initially is making sure that the cultures were collected from 2 different sticks, so not from the same site. That's also another one to kind of focus on. That's my first approach here.
I love your approach. And if you notice, what I was seeing, that things that he focused on, he said lines, wounds, DVT. And if we're gonna frame this, we can frame it in 2 ways, or we can have 2 lenses to watch this. So the first lens is just what are the causes of fever? And then the other lens is what are the causes of fever post-op? And under post-op complications, if you remember those from wind, water, and the mnemonic for those, but they're essentially clot is one of them. So DVT is one etiology. Another is wound infections. The third one is medication related. And a lot of times atelectasis is thought as a reason for fever, but that has been mostly debunked. It's thought to be based on very, very old studies. It's never been proven that atelectasis causes fever. But then that is one lens, but you also want to overlap that lens with the 5 most common infections in the hospital. And if you listen to like CP solvers, you've probably heard this multiple times already, is that the most common causes of infections in general are going to be UTI, pneumonia, skin soft tissue, intra-abdominal, and bacteremia of unknown source. So when I would evaluate that patient, I would do exactly like what Steve was saying. So essentially, ask them about are they having any infections of UTI? Are they having a cough, any symptoms of pneumonia? I would look at all of their like skin. Are they developing a rash anywhere? I would palpate their abdomen, and then I would assess for the post-op complications. Do they have a DVT? How's their wound? Are they things like that? And these are exactly what I would think of. So blood cultures were drawn at this time again, and antibiotics were empirically started. I'm gonna fast forward because the blood cultures returned 2 out of 2 Staph aureus. And I know this is a lot of times we would look this up or ask our colleagues, but do you have which antibiotics would you choose at this time? If, for example, the options being like vancomycin or cefazolin or a combination of the two, do you all have a framework for what antibiotic we would choose for just Staph aureus in blood?
Maybe can I ask a short question about the Staph aureus? From the different cultures, did they have similar antibiograms, or were those different antibiograms?
So we don't have the antibiograms yet.
Okay.
So the only thing that's reported so far was just the Staph aureus.
All right.
And why do you ask that, Julian?
So in the case of different antibiograms, it could also be repeated contaminations. If it's always the same antibiogram, it speaks for one true underlying infection.
Youssef, how sick is the patient at this point?
So when we examined the patient at this point, they had a fever to 38.5. They were resting in bed, did have some chills, and they were physically diaphoretic, but their blood pressure they were not hypotensive per se. And at this point in time, they did not have any localizing findings on exam. All their lines were also examined, and the wound was examined, and we did not find any abnormalities on that exam. So like Julian was saying, so the antibiogram will be very important to decide the antibiotics and decide how many sources do we have per se. And if a lot of times we would look at the hospital antibiogram to decide what are the resistance patterns, or what is the percentage of resistance to this particular antibiotic. Vancomycin is the typical empiric coverage for MRSA, and usually cefazolin, for example, or cephalosporin or oxacillin or nafcillin is the empiric coverage for MSSA, which is methicillin susceptible Staph aureus. There are now multiple studies that show that cefazolin is superior to vancomycin for MSSA alone. And a lot of experts recommend, if you have a high suspicion for an infection, actually starting both an anti-MSSA agent and an anti-MRSA agent in a combination until you can de-escalate. And this is like a pattern changing in that we choose a combination therapy before switching to vancomycin. Although vancomycin or daptomycin, for example, do cover MSSA, the outcomes were not as good as like a cephalosporin or oxacillin or nafcillin. And that's why the empiric therapy is recommended is both. Other things we would do is like repeat blood cultures, start considering endocarditis, beginning TTE, and then consulting ID. Although consulting ID sounds just like something we should do because of an endobacterial infection, which is I highly recommend, this has also been proven in studies, and that consulting ID can improve mortality in patients with Staph bacteremia.
In fact, in a lot of institutions now, I think particularly mine, if a blood culture pops positive for Staph aureus, it will automatically put in an order for an ID consult to be put in. The other thing is that what about the utility of swabbing the patient's nose and looking for like doing a PCR for MRSA? And if that comes back negative, then maybe using that to de-escalate or narrow.
Yeah, that's an excellent point. So for everyone, just to clarify that point, is that there's this new emerging method of essentially getting a swabbing their patient's nose and checking for MRSA as a PCR, which is like DNA detection, which is very fast, can happen over hours. And there are been a number of studies to assess for the whether not detecting MRSA, the sensitivity of the test, can we discontinue vancomycin? Now, this has been proven the highest yield with sensitivity and specificity in pneumonia. And there are now emerging studies for all the other infections. Essentially, there are emerging studies for skin and soft tissue and bloodstream infections. But as far as my knowledge is that at this point in time, some of the evidence is strongest behind pneumonia before the other organ systems. And I think that will be an emerging thing in the future. And just to add, Wasim, did you have something to say?
Yeah, just for the most recent study for non-pneumonia associated. So it depends also, this patient, do we think this patient has a pneumonia and has a bacteremia as a complication of that? Would be a special situation. But if we don't know where this is coming from, the nasal PCR correlates 85% of the time with a negative MRSA in the blood as well. It's higher than 95% when we are talking about pneumonia. So there's still like a 15% chance of having MRSA in the blood and negative MRSA in the nares, which makes it still not as good as we want it to be in terms of de-escalation method. But there are ways like they can do now, basically PBP2A mutations, MEC-A and MEC-C mutations, testing on the Staph aureus very quickly, and they can give you the result very quickly as well on the blood directly. So that might prevent this whole problem.
Yeah, thank you. So one framework that I had for like Staph aureus is also like thinking about where it came from and where it went. So it's like Cotton Eye Joe, where did you come from? Where did you go? Essentially, thinking of sources like skin, lines, wounds, procedures, and then where did it seed? Like, did it seed the heart valves, the joints, the brain, the lung? Can cause abscesses, can seed the bone, cause osteomyelitis, and in the spleen, for example, and cause like infarct. So that's what we were doing. We consulted ID. We would come every day. We would examine every single joint. We would look for any back pain, and we take any symptom that the patient says very seriously. And those, if they have back pain, I would immediately consider, does the patient have an abscess in their back, for example, or do they have seeding of any joint? So on the next day, the patient started developing a rash on the left lower extremity, essentially red spots on the nails of the left foot, and then on the soles of the feet of the left foot only, having tender spots. And we did a full exam. The TTE was negative, a TEE was negative, and the next day the spots started to evolve, but they were only on the left lower extremity. I wanted to see what you all thought about this aspect, is that the new developing rash, and what would be your next best step?
I have a couple thoughts on this. I forget who wrote the paper, but the Yale ID Twitter page tweeted out this paper a while ago on the dermatologic findings and endocarditis, which I think is on everyone's mind since we're seeing skin findings in a patient with Staph aureus bacteremia. Classically, you see like petechiae, and like in the conjunctiva of the eye, like we pull the eyelid down, you can see that. But more commonly, the paper showed that purpuric lesions are actually the most common finding you see in infective endocarditis of any cause, more so than those like eponomic names that you see, like Janeway lesions and Osler's nodes, which I think are the painful ones. But yeah, I think just off the bat, that's concerning that this patient has endocarditis. And Ravi saying purpura fulminans, that would be really bad.
Yeah, excellent thought. What are your thoughts about just having the lesions on the left extremity only and not the right?
Yeah, that's curious. I guess if something was like dislodged proximally, like during the procedure, and maybe like went downstream, something could happen. But off the bat, I can't think of something.
What
And,
side did they come in? Sorry.
No, please go ahead, Claire.
I was gonna say, what side did they enter when they placed the stent? Where did they do it, from the femoral or from the radial, and what side?
Yeah, excellent thought. So they went through the left femoral and went up to the carotid. What were you thinking, Claire?
All right, well, I'm thinking of dislodgement, which a lot of people have been mentioning in the chat. A cholesterol emboli or something like that that was dislodged, or if they actually introduced, if there's a foci of infection where they entered at the femoral artery.
Yeah, excellent. And that's what we were thinking as well, as in what was the site of the initial catheterization, and the wound site looked clean without any erythema or discharge, but there was tenderness around the wound. And our suspicion was like, why is the TEE negative with these like lesions developing only on the left lower extremity, and not just the foot, they develop proximally as well. And we were thinking exactly like you were thinking, what is the differential of like these possible emboli? And we were thinking of, could this be a cholesterol embolus? Could this be a septic embolus? And what is the thing that actually got dislodged? So we got a CT scan of the abdomen and pelvis, and essentially there was a huge collection around the wound consistent with abscess. And the abscess wound was essentially draining into the vessel and causing emboli exclusively on the left lower extremity as an endovascular infection outside of the heart. And the patient, that was like our final diagnosis. The patient went back to OR, unfortunately, but got that drained and with complete resolution of the cultures and the symptoms.
Yeah, we always talk about Lemire's kind of being very related to endocarditis. I feel like this is similar, just in a different location. I've never seen this before. That's really cool.
Yeah, so it's exactly like an endovascular infection outside of the heart. And like Andrew was saying, it's like an analog to Lemire's disease or infective endocarditis. Does anybody have any like thoughts or reflections about the case, or any like questions about the management that throughout the steps that we took?
Was there any concern for the stent? Because if it was like introduced from this area of like where there's clearly staph being introduced past the skin, was there any concern for the stent? Did it have to be re-imaged? Make sure there wasn't like an emboli there too, or infection pending there.
Yeah, we were very concerned, essentially because like staph can essentially seed any bioprosthetic film, can form a film on any like foreign material. And fortunately, the cultures cleared, correlated with the procedure. And there were no symptoms after the procedure was done. And we were assessing daily for like any signs and symptoms. The patient like defervesced, and we were examining daily afterwards with no symptoms that appeared afterwards. And the patient was safely discharged, followed in clinic without the emergence of any of the symptoms. But that definitely was one of our concerns. And definitely the patient got a long course of antibiotics as well.
Youssef, great case. I've had many situations where initially there was something like this, maybe a fever, something sending smoke signals that there could be a potentially developing infection, but then not thought to be an overwhelming infection, then later morphs into this ginormous presentation of sepsis and this abscess formation and so on. So we always look in retrospect, was there something that was missed? Was there some sort of maybe bandemia in the differential, some inkling that there was something that could have indicated to us that there was an onslaught of an infection? But here I guess it's difficult to figure out, and that's what I always challenge myself with in reflecting on such cases. But that's quite a serious manifestation of this infection. I don't know if it was, would you trace it back to being just intraoperative, postoperative, or could this be in developing? Because you're just getting a snapshot in time at the beginning, but maybe there was an infection in situ in development.
Right. And it was presumed that the infection was through the skin around the wound and was forming an abscess around the groin area. This was essentially like an elective procedure. The patient came in for a procedure after the stroke, a couple of months after the stroke, and there was no concern that the patient had any other comorbidities, and there were like no signs before the procedure of like anything like was gonna develop or any signs of illness. And then after the procedure, it took some time for the signs to develop. And that's the.
Oh, sorry, go ahead.
No, please go ahead.
I was just saying, yeah, this post, I get consults for things like this, and yeah, post-operative complication, I guess you have to then trace it back to the procedure itself, like you mentioned. So what happened? What were the circumstances surrounding the procedure? What kind of a procedure it was? And then that was very interesting that just like Andrew was thinking, the left leg, and then you sort of walk it back to the leg, which was the site of the procedure. But you really have to sort of be working like Sherlock Holmes, try and figure out where did this come from, and like you said, where did it go, like Cotton Eye Joe. So a great case. So really, this is a real life situation. You'll come across it. I've come across it before, and definitely is always a learning process.
Yeah, does anybody have any like reflections about the case or anything else they wanted to anything they learned or anything new that they learned about this case?
I'll just say that I've seen in my residency so far, half my MRSA endocarditis or MRSA bacteremia cases are people who were treated, but then they have recurrence just because they had like seeded somewhere in the back and they had osteo still there that wasn't completely treated. I just had a case in the ICU, I'm in ICU right now, of septic arthritis like 6 months after they were treated completely for MRSA bacteremia. So a lot of the times this nasty bug can recur because it hides in places. But also I'm biased because I see a lot of people on immunosuppression, which I think puts people at a lot higher risk of like having recurrence. But yeah, it's very, very challenging disease to manage.
Actually, yeah, Andrew, that's an important point. That also echoes what Youssef said, getting an ID consult, because we can be very bad at trying to figure out potential seeding sites. And the data for that, the recommendation to get an ID consult was because a lot of recurrent manifestations of bacteremia that wasn't appropriately addressed in the first place. So very important to get an ID consult on board just because of the point you just made.
Yeah. Deborah, do you want to go take us through the teaching points? All right. Or I don't know if Yasmin was taking the teaching.
Yasmin, it's me.
Oh, I saw you signed in. I wasn't sure if you're the one who were taking them.
I'm the anonymous wombat right now. So for the teaching points, thank you so much for this management VMR. This was really fun and great insights for whoever watches this, and it's already in the works. So our first teaching points and approach to the infection in a hospitalized patient. First, monitor vitals. Is there leukocytosis? Is the patient febrile? And then second, think blood cultures. Why would you get them in the first place? And when you get them, identify the organisms. That's why everybody was asking, was it chains? Was it clustered? Now identify the organism in the blood culture. For example, for Staph epidermidis, you think maybe there can be contamination? For aureus, treat. For staph lugdunensis, which is a new one for me, it can act aureus, and it can cause CNS infection, endocarditis, UTI, peritonitis. You take it. It causes a myriad of infections. And second, if it's not conclusive, may repeat blood cultures. But it takes us to the next question. We repeat them or we start antibiotics. If a patient is suspicious for an infectious disease, in example, he's symptomatic, he's febrile, we can repeat the cultures and reassess the patient if he is stable. But then we think, what are the causes of fever or post-op fever? As you very brilliantly said, we can check the lines, wounds, DVT, meds. There are most common causes of infections, let's say bacteremia of abdominal source, UTI, soft tissues infection, lungs, and do not forget to check access sites of evidence and cellulitis or purulence, as Dr. Andrews said in the chat. Now, how do we start antibiotic treatment if we do? For MRSA, you can start with Banco. There have been evidence that cefazolin can be superior for Banco, but if not, you can start a combination until you can de-escalate antibiotic therapy. We also went into asking, superior from MSSA. Thank you, Dr. Ali. Now for no swabs, we're thinking no swabs or PCR. The negative predictive value of MRSA swab NAIRS is from 90 to 99%. Again, thank you, Dr. Andrew, for the input. And it correlates with 85% negative for blood MRSA presence. So it's not as good for de-escalation. Now, we also found out that the PCR detection and blood for MRSA is a faster method and preferred. And last teaching point, an approach to ration petechiae in a febrile patient, we can do a CT abdomen and pelvis to assess vasculature, and in a patient with a previous stent placement, suspect bacteria that form biofilm. And these are the teaching points for today. If there is anything wrong with it, an input is very well appreciated. Thank you all.
Wow, Yasmin, excellent teaching points. And thank you all, everyone, for joining for the case today. And hopefully we learned a little bit more about like staph bacteremia, and next time maybe we don't panic if we get the call of having GPCs in blood. Thank you, everyone.